Back. Yes, Dr. Rebika, please.
Thank you, ma'am. I think a little more tickling of the brain because we have another topic in neuroophthalmology, which is your typical visual field defects. Now, it's important not only for your exams, but also for your PG or fellowship exams because these type of field defects could be asked, okay? So first, understand why to do a visual field examination. So first, because it helps you in the diagnosis of the neuroophthalmic conditions, then it gives you a probable idea about the site of the lesion. And in certain conditions, it acts as a screening tool, like in toxic optic neuropathy. A patient on ATT comes to you, you should get a baseline color, contrast, vision, and visual fields, so that when the toxic optic neuropathy starts, you can catch it on time. Then on follow-up, you can monitor the disease progression and accordingly guide the treatment, like cases of IIH and pituitary adenomas. And lastly, when patients with a permanent vision loss, you can evaluate the disability scores. So many a times, we give handicap certificates based on the visual field defect, and also it guides the patient rehabilitation. So how can you assess it? Just in brief, you can use either automated static perimetry like Humphreys, or you can use a Goldman kinetic perimetry, especially if you want to have an idea of the peripheral visual fields. Now, if nothing is available, you're sitting in a peripheral center, use a confrontation test. Confrontation is a simple bedside test that will give you a gross idea about the large field defects. And sometimes we have also used Amsler's grid to chart central or centrocecal scotomas. So normal limits of visual field, superiorly and inferiorly, it's almost 60 to 70 degrees. Nasally, the field is a little limited as compared to temporal. Why? Because the nasal bridge comes in. Now, a few terminologies that you should know before we discuss this topic. One is hemianopia. That's the involvement of 1/2 of the vertical visual field. Quadrantinopia, involvement of 1/4 of visual field. Homonymous term basically means the involvement of the same side of the vertical midline. To brush up your basics of the visual pathway anatomy, the receptors are the neural epithelium of the rods and cones. First order neuron are bipolar cells, second order neuron are the ganglionic cells. Then the axons of the ganglionic cells make the optic nerve. Then from the optic nerve, you have the chiasma. So what is interesting about chiasma? The lateral fibers go into the same or the ipsilateral side, but the nasal fibers, they decussate over to the other side. And that constitutes your optic nerve, optic tract. From the optic tract, the fibers end into the lateral geniculate body. And from the LGB, the third order neuron arises, go into the optic radiations, and end in the occipital cortex. Now, this is a very important slide because it covers the major share of this topic, if read properly. So it tells you that what are the various types of defects that you will see based on the site of the visual pathway involvement, and I'll be discussing them one by one. So first, what's the relationship between the visual fields and the retina? So remember that the image that is formed on the retina is inverted and reverse. So inverted means the superior falls below and the inferior falls above, okay? And similarly, reverse means that your left side of the visual field is projected on the right half of retina, and your right half of the visual field is projected on the left half of the retina. But visual fields are not mutually exclusive as you see over here. Rather, they are overlapping. So you have a large overlapping central binocular visual field, and there is a peripheral rim of monocular visual fields. Now, what type of field effect will you get? Well, in retina, it depends on which layer is affected. If your outer retinal layers are affected, there's no particular pattern to it. But if inner retinal layer, that is nerve fiber layer, is affected, then it is there that the patterns begin. So why? Because nerve fiber layer has this peculiar arrangement, which you all must have read in anatomy. You have papillomacular bundle directly going from fovea to the optic nerve head. Superior and inferiorly arching are the arcuate fibers, and then you have the radiating, superior and inferior radiating fibers are present nasally. So because of this arrangement of nerve fiber layer and the way they enter the optic nerve, you have this kind of the fiber arrangement in the optic nerve head, where you see the macula present temporally and rest of the fibers arranged nasally. Then also peculiar is that the peripheral fibers arising from the peripheral retina, they remain peripheral in the optic nerve, while the macular fibers, they remain central. So as you move from the nerve head to the optic nerve, the macular fibers, they become more central. Now, coming to the field defects. Now, what type of field defects will you get if RNFL or optic nerve head is involved? Well, depends on the type of nerve fiber bundle which is affected. But what is characteristic is that these defects will originate from the blind spot and not from the central fixation, and also they will respect the horizontal midline, okay? So if there is an involvement of the papillomacular bundle, you might see a central scotoma, that is here, a centrocecal scotoma or a paracentral scotoma. If there is an involvement of the arcuate fibers, you might see an arcuate scotoma and altitudinal defects. And if there is nasal fibers which are affected, you will see temporal wedge-shaped defects. So this is one example. Can you tell me what type of scotoma is this? So yes, it's a centrocecal scotoma because it's, yes, it's connecting the fixation with the blind spots. That becomes a centrocecal scotoma. So this is a typical differential that you will, the typical differentials would be optic neuritis, toxic, nutritional, hereditary optic neuropathies. In my previous presentation, I showed you that how a case of LHN presented with central scotomas, okay? So now another case, what you see in this right eye, so there is a disc edema. But what is typical is it's a pale disc edema, not a hyperemic disc edema. So hyperemic disc edema goes in favor of papillitis. Pale disc edema goes in favor of ischemic optic neuropathy. And when you get the visual fields done, you see an inferior altitudinal defect. So this is a case of NAION. So sometimes you might get confused between inferior arcuate defect versus a pie on the floor, which is a quadrantenopia, okay? So this picture, what do you think it is? It is an arcuate or a pie on the floor? So had it been a case of an optic nerve lesion, then it would have been connected to the blind spot and it would respect the horizontal midline. But what you see over here is that it's respecting the vertical midline and it is connected to the central fixation, okay, arising from the central fixation. So this is more likely a retrochiasmatic lesion that's causing a pie on the floor. So arcuate field defects you not only get in glaucoma, but you might get in other conditions like choroiditis, CRAO, BRAOs, papillodemas, especially chronic papillodemas. So this is differentiating features between the lesions which are present anterior to chiasma versus the lesions at or posterior to chiasma. So anterior to chiasma, basically it's an optic nerve involvement. So it will be usually unilateral. Unless it's a bilateral pathology, there could be RAPD. You can see disc changes like edema or exudates, and the field defect is unilateral. But if it's posterior or at the chiasma, the bilateral pathology, the bilateral field defects begin. The vision loss becomes symmetric and bilateral. You do not see an RAPD, you might see a vernix pupil. And the disc might just show a pallor, but you might not see any other pathology in the disc. In optic chiasma, what is important is that apart from the nasal decussation, you should know about the von Willebrand's knee. So what is that Willebrand's knee? Well, when the lower nasal fibers are decussating in the chiasma, it actually takes a little turn into the posterior part of the contralateral optic nerve before it joins the optic tract. So these lower nasal fibers actually represents the superotemporal field, and its clinical significance I'll discuss later, okay? So, and you should be aware of what are the various relations of the chiasma around it, because these relations can actually tell you that what type of defect and where the lesion could actually be. So if it's a case of cellular or supracellular tumor, it will cause a central chiasmal compression, and since it is the nasal fibers, it is affecting the crossing nasal fibers. So nasal fibers means your temporal visual field. So what type of defect you will get? Bitemporal hemianopias. So an immediate indication for neuroimaging, and the DDs would be pituitary adenomas, craniopharyngiomas, or meningiomas. Rarely you can get a lateral compression of the chiasma instead of central, and here you might see binasal hemianopias, but it's very rare. Then what's the significance of von Willebrand's knee? So it's actually it indicates that if there's a lesion at the junction of the optic nerve and the chiasma, so what happens is that it not only involves the affected nerve, but you also get some scotoma in the contralateral eye. So lower nasal fibers are forming the Willebrand's knee in this optic nerve. So you get a superotemporal defect. So this is called a junctional scotoma. So this indicates the lesion is at the junction of optic nerve and chiasma, okay? So that is about the Willebrand's knee, so you might get a question related to it. So in optic tract onwards, the temporal fibers of ipsilateral eye and nasal fibers of contralateral eye both combine together and represent one half of the binocular visual field. So from here, the visual field defects, they become homonymous. So, but remember that as you go more towards the visual cortex, they become congruous. So what is congruity? Congruity means the exactness of the visual field defect in the two eyes in terms of size, shape, location. So the more you are towards the cortex, the more congruous the defects are. So you see in case of optic tract lesion, you get incongruous defects. You might also get a little atrophy and vernix hemianopic pupil. So what is a vernix hemianopic pupil? Half of the retina, intact retina, you're projecting the light, you get the pupillary response. On the affected half, if you're projecting the light, you don't get a pupillary response. So LGB, it is typical for sectoral homonymous hemianopias because it has this typical blood supply because of that. Then optic radiations, the third order neurons arising from LGB, they move into the optic radiations. Now here there's a differentiation. There are two fibers, superior fibers and inferior fibers are separated. So your inferior fibers coming from inferior retina, but they represent the superior visual field. So they pass into the temporal lobe. They form the Mayer's loop. So if this is affected, you get a pie in the sky. So temporal lobe, pie in the sky. And while the superior fibers representing the inferior visual field, they pass in the parietal lobe. So parietal lobe lesion will cause a pie in the floor. So this is one example of a pie in the sky. And when we did a MRI, what we found was a MCA infarct, and that was affecting the temporal lobe. So other neurological signs that may be seen in temporal lobe lesions could be seizures, aphasia, or hallucinations. Then in parietal lobe, asymmetric optokinetic nystagmus is one feature. So just look for other associated neurological and systemic signs, okay? So finally comes the occipital cortex. Well, as you see, that macula has the highest representation. Almost 70 to 80% of the tip of the occipital lobe is actually representing the central 30 degrees of the visual field. And rest of it is, the superior fibers are projected on superior to calcarine fissure and inferior fibers inferior to calcarine fissure. So here you get congruous contralateral homonymous hemianopia. Okay, very typical. And you see like a right homonymous hemianopia, and you see a left-sided occipital lobe lesion. Sometimes, just my last slide, sometimes you might see a small macula sparing defect, okay, homonymous hemianopia. Now, why do you get this macula sparing defect? You need to understand the blood supply, okay? So blood supply of the occipital or the tip of the occipital lobe, it is receiving the blood supply from both PCA as well as the MCA, so posterior and middle cerebral artery. So in case of a PCA infarct, the branches from MCA still continue to supply the occipital lobe tip. So if this anastomosis is present in a patient, then the tip is spared and you get this macula sparing.
I think we
lesion.
can wind up,
Yes,
Dr. Rebika.
So that's it. And just last slide where you see that sometimes there could be coexist, the pathologies may coexist. So we had this case of a glaucoma on follow-up for quite some time. You see these typical arcuate defects, but what he recently developed was this kind of a hemianopia. So this warranted immediate neuroimaging, and the patient, we did find something in the brain. So remember that even with a known pathology, if the patient is on follow-up, a regular follow-up visual field scannings are important.